Begin by preparing the environment and the patient. The assessment should be performed in a warm, quiet and private setting to promote relaxation and cooperation. Ask the patient to empty their bladder before you start, as a full bladder can interfere with your findings and cause discomfort. Position the patient lying flat on their back with their arms at their sides and legs uncrossed. Support the head and knees with small pillows or rolled sheets to relax the abdominal wall and make the assessment easier. Ensure the patient is adequately draped to maintain privacy while exposing only the abdomen. Before touching the patient, always explain the procedure and gain their consent. Use effective communication to reduce anxiety and encourage the patient to share any symptoms or concerns, such as pain, bloating, nausea, vomiting, constipation, diarrhea, or changes in appetite. Take note of any previous abdominal surgeries, injuries or medical conditions. This initial conversation provides context for your findings and helps you tailor your assessment. The abdominal assessment follows a specific order: inspection, auscultation, percussion, and palpation. This sequence is different from other physical assessments because touching or pressing on the abdomen before listening can alter bowel sounds and lead to inaccurate conclusions. Start with inspection. Stand at the side of the bed and look at the entire abdomen. Observe the general shape and contour. The abdomen may appear flat, rounded, scaphoid, or protuberant. A flat or slightly rounded abdomen is usually normal, while a scaphoid, sunken, or protuberant, bulging, abdomen may indicate underlying pathology. Look for symmetry between the right and left sides. Asymmetry can suggest the presence of masses, organ enlargement, or hernias. Assess for abdominal distension, which may be caused by gas, fluid, or enlarged organs. Note any visible masses or bulges, which could be hernias or tumors. Examine the skin for color, scars, rashes, lesions, or striae. Striae are stretch marks that appear as silvery or white lines and may result from rapid weight gain, pregnancy, or certain diseases. Scars may indicate previous surgeries or trauma. Look at the umbilicus to ensure it is midline and inverted. An everted or displaced umbilicus may suggest hernia or ascites. Observe for visible pulsations, which can sometimes be seen in thin individuals or in cases of abdominal aortic aneurysm. Watch for abnormal movements, such as visible peristalsis, which may indicate intestinal obstruction. Next, proceed to auscultation. Using the diaphragm of your stethoscope, listen to bowel sounds in all 4 quadrants. Normal bowel sounds are soft gurgles or clicks that occur regularly as the intestines move contents forward. Listen for at least a few seconds in each quadrant. Bowel sounds are considered normal if present and active in all areas. Hypoactive or absent bowel sounds may indicate ileus, peritonitis, or late bowel obstruction, while hyperactive sounds can occur in early obstruction or gastroenteritis. Also listen for vascular sounds, such as bruits, which may suggest turbulent blood flow in the abdominal arteries and could indicate vascular disease or aneurysm. Percussion is the next step. Gently tap on the abdomen to assess for differences in sound. Tympany, a drum-like sound, is normal over air-filled structures like the stomach and intestines. Dullness, a flat sound, is expected over solid organs such as the liver or spleen and may also be heard over fluid or masses. Percuss systematically across all quadrants to map out areas of tympany and dullness. This can help identify enlarged organs, fluid accumulation, or masses. Percuss the liver and spleen specifically to estimate their size, as enlargement may indicate disease. Percuss the costovertebral angle at the back to check for tenderness, which can suggest kidney inflammation. Palpation comes last. Begin with light palpation using the flat of your hand and fingers. Gently press into the skin about 1 centimeter, moving in a clockwise direction through all quadrants. Assess for muscle tone, tenderness, masses, and abnormal resistance. If the patient reports pain, palpate that area last to avoid unnecessary discomfort. Watch the patient's face for signs of pain or discomfort during palpation. Guarding, or voluntary tensing of the abdominal muscles, may occur due to anxiety or pain. Involuntary rigidity, where the muscles remain tense even when the patient tries to relax, is a sign of peritoneal irritation and is more concerning. If you are trained and it is appropriate, proceed to deeper palpation to feel for enlarged organs or deep masses. Use both hands to gently press deeper into the abdomen, again moving systematically. Palpate the liver edge in the right upper quadrant, the spleen in the left upper quadrant, and the kidneys in the flanks. Palpate the bladder in the lower abdomen to check for distension. Always be gentle and stop if the patient experiences significant pain. Assess for rebound tenderness by pressing slowly and deeply into an area of the abdomen, and then quickly releasing your hand. If the patient experiences sharp pain upon release, this is a positive sign and suggests peritoneal inflammation. Only perform this test if you suspect peritonitis and are trained to do so, as it can be very uncomfortable. Throughout the assessment, compare your findings to what is expected for the patient's age, body type, and medical history. Document any abnormalities and report urgent findings promptly. Now let's discuss common red flags that may indicate serious abdominal pathology. Recognizing these warning signs is crucial for timely intervention and can be life-saving. A sudden onset of severe abdominal pain, especially if it interrupts sleep or is described as the worst pain the patient has ever experienced, is a major red flag. This can be a sign of conditions such as perforated ulcer, ruptured aneurysm, or acute pancreatitis. Signs of shock, including low blood pressure, rapid heart rate, confusion, or decreased consciousness, are very concerning and may indicate internal bleeding, severe infection, or organ failure. Pain associated with peritonitis often presents as guarding, rigidity, and rebound tenderness. The patient may lie very still to avoid aggravating the pain. Peritonitis can result from perforation of a hollow organ, such as the stomach or intestine, and requires urgent surgical intervention. Gross abdominal distension, particularly if it develops rapidly, may suggest bowel obstruction, massive ascites, or internal bleeding. Distension accompanied by vomiting of fecal or bilious material is especially alarming and requires immediate evaluation. Altered bowel sounds are another red flag. Absent or very reduced bowel sounds may indicate paralytic ileus or late-stage obstruction, while high-pitched, tinkling, or hyperactive sounds can be heard in early obstruction. Vomiting blood, known as hematemesis, or passing black, tarry stools, known as melena, are signs of gastrointestinal bleeding. Fresh blood per rectum, called hematochezia, is also a red flag and may indicate lower gastrointestinal bleeding. Visible bruising around the umbilicus, known as Cullen's sign, or on the flanks, known as Great Turner's sign, may indicate internal bleeding from conditions such as hemorrhagic pancreatitis or abdominal trauma. Palpable masses, especially if hard, fixed, or irregular, may represent tumors or abscesses and require further investigation. An irreducible hernia, especially if tender or associated with vomiting and distension, suggests incarceration or strangulation and is a surgical emergency. Jaundice, or yellowing of the skin and eyes, may be associated with liver or biliary disease and should prompt further evaluation. Persistent fever, chills, or night sweats in association with abdominal pain may indicate infection or abscess formation. Unexplained weight loss, Persistent vomiting, and loss of appetite are concerning symptoms that may point to malignancy or chronic disease. In pediatric patients, abdominal pain with guarding, rebound tenderness, or refusal to move should be taken seriously, as children may not be able to describe their symptoms accurately. In women of childbearing age, always consider the possibility of ectopic pregnancy or complications related to the reproductive organs, especially if abdominal pain is associated with vaginal bleeding or missed periods. During your assessment, always consider the patient's overall appearance and vital signs. A patient who appears pale, sweaty, or distressed, or who has unstable vital signs, requires urgent attention.